for Professor Gamal, as we all know, he had been joining us for the last few months. He's a professor of surgery at Wayne State, and زي ما بنقول هو قني عن التعريف. He's the chief of surgery at Detroit VA Hospital in USA, and today he's going to talk to us about the esophageal perforation. You can start highly welcome.
Right. So, Muhammad, so who can we run this by? Just a few scenarios here. Who you think? Any suggestions?
I think anyone can be the volunteer of today's session. You can start asking question and everyone can answer the question.
So today we're going to talk about esophageal perforation, and just to get an idea, guys. So I kind of like see how much important is the topic for everyone here. In Sudan, for instance, do you see some of these cases, guys?
Actually, for those working with Professor Rashid, he's running the only upper GI unit. So actually, most of the cases are directed there. So I have worked with him for a very long time, and we have seen many of these cases.
So what do you think is the most common thing to cause this in Sudan?
Actually, usually it happens during quarrels, like gunshots, knife injuries, and that. We don't have like the Fairhoff syndrome, during vomiting and that, because there is not much alcohol drinking in our setting. But I think usually it's traumatic one, which is the most common. Anyway, it's very rare, to be honest. It's not that common.
Okay.
Maybe during the last 7 years, we have seen like 2-3 cases, but usually it's traumatic.
Yeah, you're right that it's not as common, but it's kind of really dangerous. So, Fatima, Fatima, are you one of our registrars or senior registrars? Fatima, are you one of our registrars or senior registrars? Can you hear me? Muhammad, can she hear me?
Yes, I hear you, but I think it could be due to internet connection. I think you can ask anyone can answer this question.
So, Anas, Assalamu alaikum. Anas, can you hear me? No? Okay.
We have a lot of senior registrar. You can ask anyone. Anyone can answer the question, Professor.
Okay, so it's going to be the next one. We are talking about a case. The most common cause of esophageal perforation, at least what we see here, is esophageal instrumentation of some kind. That's the most common one. I have to ask someone if they want to pick up this case. A 60-year-old man with dysphagia and weight loss is undergoing endoscopy. They found the mass in the distal esophagus. They do biopsy of this mass. And after the procedure, he complains of chest pain shortly thereafter. How would we approach that? If somebody can work with me on this, please. Anyone?
Prof, I can give it a shot.
All right, Ismail, right. And just to add one thing, Ismail, they sent a frozen section of the biopsy of this mass in the distal esophagus, and the frozen section came back as invasive adenocarcinoma of the esophagus. The man is now in a recovery area after the procedure and is complaining of chest pain retrosternal chest pain. Can you tell me how you would approach this?
So he's in recovery area and you would check if he's hemodynamically stable. You would listen to his chest if there's any obvious signs of decreased breath sounds. You would order an erect chest x-ray, and you'd probably want to look for free air or mediastinal air because you're worried about a perforation. He's 60 years old, so cardiac troponins is also indicated. You want to exclude other causes of his chest pain. By then you'd have an idea of exactly what happened, but you're worried about a perforation.
So what kind of workup you're going to order? He said an upright chest x-ray, and what else? What else you want to order? He is hemodynamically normal. He's hemodynamically stable. You order an upright chest x-ray. Anything else you'd like to order?
You can, I mean, if you're not sure, you can order a CT of the chest.
What would you like to order? You know, this is you're managing this patient. So you have an upright chest x-ray. Do you want to order anything else?
I would like a contrast, an investigation with oral contrast, water soluble.
You mentioned EKG, right? You didn't want that?
Yes. You should have an EKG. That's the correct, Prof. Sorry, I completely forgot about that.
Okay, the EKG shows sinus tachycardia, and the chest X-ray is normal. The upright chest X-ray is normal.
So you haven't really found the cause of his chest pain, and it's nice to inquire from the endoscopist exactly what transpired at the time of the biopsy. So you have an idea of how high risk the procedure was. So if you are worried, then you need a further investigations in the form of a CT chest or at least a contrast swallow.
What would you like to get at this point?
I would go for a CT chest.
And what kind of CT?
With IV and oral contrast.
Okay, so you do the CT scan and it shows extravasation of contrast in the left pleural space.
Okay, so now it's an early, it's a perforation. It's an early perf because you've just found it. You have an option where you would either want to try and manage this endoscopically, or you would want to go for surgery. This is a malignancy. It's a distal mass. You're not going to be able to manage that easily with surgery. Your option now is are you going to drain the area, open drainage, or are you going to manage this endoscopically? Your endoscopic options are multiple.
Just tell me in 2 words, in 2 options. What are the 2 options that you have for this? Endoscopic management and
surgical.
And operative management, right?
Yes.
So yes. The endoscopic management, what do you mean by that, by this? What do you mean by the endoscopic management?
So intraluminally, you can either stent it or you can clip it. You can put in a staple or clip over the perforated area.
Okay, right. So why do you think this option is a good option? What are you achieving here?
So because it's an early perf and you've got imaging to tell you that it's localized to the left side, he's an elderly gentleman that may not do well with open surgery, and it's a malignancy likely in view of the scenario.
This malignancy, the frozen section showed invasive adenocarcinoma of the distal esophagus.
Okay, so it's a good option. And in view of all this, it's a good option to manage it endoscopically. It's less invasive and better for the overall.
What do you mean management? So management meaning definitive management, or what do you mean by management? What's your plan on this man? Endoscopic, you're going to do clipping. How do you think clipping is going to work for cancer?
it's not going to work well because the mucosal integrity is not good. It's probably irregular. It's going to be friable.
Okay, so how do you want to manage that endoscopically?
You can put in a covered self-expanding metal stent.
Okay, and what would be the plan after that?
You need to make sure that well, now that you've closed it up and there's no further leakage, you need to make sure that this hasn't turned into sepsis in the form of a mediastinitis. It allows you then to also optimize your patient in terms of fluids and nutrition.
Sure, but just tell me what you're gonna do. So, hey, you notice, Ismail, the emphasis here is on you need to tell us exactly what next step you're gonna do. Let's say, assume that the stent is in.
Yes.
What else you have to do for this patient?
You can put in the chest drain.
How are you gonna do this?
We could do it. Well, a normal intercostal thoracostomy, you could insert that as you would do in the normal emergency room.
So just regular chest tube. Right?
Yes, yes.
What else are you going to give him? So far, this patient had stent and chest tube. As far as we're concerned, we didn't hear you do anything else for him. Anything else you want to do for this man?
You can start him on antibiotics.
You can, or you should, or?
You should.
Okay, what kind of antibiotics?
Broad spectrum antibiotics. Okay. Possibly amoxicillin clavulanic acid.
But what's your goal of coverage? What about organisms? Not a specific organism, group of organisms.
You're covering your aerobic and anaerobic organisms.
And gram-positive and gram-negative, correct?
Yes, Prof.
Okay, so broad spectrum intravenous antibiotics. So far, so that's why we're doing this, guys, so we can learn how we think and stay on track of exactly what we are going to do for the patient. So the first thing that should actually jump in your head in any of these cases is intravenous fluid resuscitation. This patient should really get aggressive volume resuscitation. Why do you think this is?
Well, there was minimal leakage there. I'm not sure. I mean, you mean aggressive volume, almost as if you're resuscitating a trauma patient.
Now, why do you think they need a lot of volume, these people?
Because the sepsis is almost guaranteed, in my opinion.
Yeah, they really get very excessive irritation of the mediastinum, and they get severe chemical peritonitis to start with once the acid and all this is in the mediastinum. So a really aggressive volume resuscitation is really important. And broad spectrum antibiotics should be started very early. All these patients should be started very early on broad spectrum antibiotics and aggressive volume resuscitation. And you mentioned that there are two options. One of them is endoscopic management, and the other one is operative management that we're going to talk about soon. Endoscopic management, you're going to put a stent in, and you're going to drain the chest with a chest tube. So let's assume you have your volume resuscitation, you already started that. You have your broad spectrum antibiotics, you have your stenting, you have your chest tube. Do you want to do anything else for this gentleman on this track of endoscopic management?
Perhaps insert a nasogastric tube past the area so that you have feeding, you don't have any feeding problems.
So you think you'll be able to pass an NG tube beyond the tumor?
Beyond the stent.
Beyond the stent?
Yes.
And what are you going to achieve by that?
Well, at least you can get early feeding, and if yeah, okay, so it may be a conduit for you to feed past that. But of course, the stent should have achieved that anyway.
So you're going to feed him right after the stent?
No, Prof. Once everything has settled in a few days and he's properly resuscitated, and I'm sure that there's no ongoing mediastinitis or perf, then perhaps yes.
Okay, is there any other way that you can feed him to avoid all these problems?
You can opt for total parenteral nutrition as one.
Do you think that would be a good option?
It's a fair option, Prof. It is a good option in him.
It has its complications. Is there any other way that you can feed his gastrointestinal tract still?
You can do a feeding gastrostomy or feeding jejunostomy.
Absolutely. You can do definitely feeding gastrostomy tube. How would you do that, you think?
So you can do all that as well, either endoscopic method or by open surgery. Now that you've got a lumen past the tube, you'd be able to pass a peg set with the introducer and be able to establish and suture that peg onto the gastric wall. The other option, if you can't do that.
Just a second, Ismail. Do you think PEG is doable in this case, after you put a stent?
It will be difficult.
I think it's contraindicated, honestly. I think
Okay.
it's contraindicated. So PEG option is not there.
Okay.
Your option is G-tube, but you can do it laparoscopically, correct?
Yes.
So you can avoid all major surgery in this gentleman. So guys, here's what we did so far. We have a gentleman with perforated esophageal cancer. Let me ask you one thing, Ismail, before I go any further. Why is perforated esophageal cancer is a unique problem compared to perforation of the esophagus in any other instance? What's so special about perforated esophageal cancer?
It's because you're dealing with the problems of the lesion and the cancer and with the perforation. So you're dealing with actually two problems, and what you do has to keep in mind what you're going to do later for the cancer. Whereas in the isolated perf, you're only dealing with the main issue, which is the perf. So you may be restricted in certain things.
Okay, I think we're going to come to that in the operative approach. So perforated.
Actually, one more thing, that it is the only one which will hold the stents, because the normal esophagus cannot hold the stent when it is perforated.
Okay, yeah, sure, absolutely. So far we got a gentleman with perforated esophageal malignancy during an endoscopic procedure. He's hemodynamically normal. We put an endoscopic stent. We started aggressive volume resuscitation. We gave broad spectrum antibiotics, and we obtained enteral access for feeding. Back to you now, Ismail. Let's assume that all this has been achieved. What is the next step in the management, and what would be your plan next?
Okay, so I would like to look at his baseline bloods after everything has happened. Look at his septic markers and his renal function.
Let's say he's improving. He's improving. Everything is improving.
Okay, so everything is improving. So now we can go on to manage his distal esophageal mass and plan his surgery.
What do you mean by that? What are you going to do?
So we would like to plan his surgery for his distal esophageal tumor.
Right. What do you mean by that? What are you going to do?
Okay, and depends what imaging we have available for that at the moment, and what it tells us, and what stage his disease is.
Yeah. Tell us what you're going to do. You can order anything you want. Just tell us what you're going to do.
So now I would like to get a CT scan of his chest and his abdomen. It will help me to stage the disease. It will tell me the size of the lesion. Well, I've seen that already. Right. It will look for nodal metastases, and I can work from there now that I've got some histology as well.
So you're going to work him up for elective esophagectomy, correct?
Yes.
Okay. Let's go to the other route that you don't really have the endoscopic option to manage this patient, right? He's hemodynamically normal. And are you going to operate?
Sorry, if you mean just after the injury?
Yeah. We don't have
just
endoscopic. We don't have endoscopic option. It's not available.
Okay. So it's a bit of a tough one because I suppose you could wait, but you have to wait and sleep with one eye open to see if...
What do you mean wait? What do you mean by that? What are you going to wait? How are you going to wait?
Watch, wait, and observe. And why I say this is...
You mean non-operative management, is that right?
Yes, non-operative management, but with a view...
What would you do if you're not operating? What would you do?
I'll put him into a high dependency area, an ICU or high care in the hospital.
Okay.
I would make sure he has proper lines and a catheter.
Mm-hmm.
I'll keep him nil per mouth for now.
Mm-hmm.
If we're going the TPN route, I'll get the dietitian to start that. And he needs monitoring. He needs a regular, at least a daily inflammatory markers and his urea and electrolytes to start off with.
And what are you going to do with the hole in the esophagus that's leaking?
Oh yes, we didn't put the stent in there.
No, we said there is no endoscopic option. You have a gentleman with a hole in the esophagus that's leaking in the mediastinum and the pleural space.
No, then we can go in and explore and repair.
But you just told me that you're not going to operate. So are you going to operate or not going to operate?
No, because we don't have the endoscopy anymore, Prof.
Absolutely. There is no endoscopy. That's what we agreed on. There is no endoscopy.
So we have to operate then.
So there is no non-operative option here, correct?
Yes.
Good. You're going to operate. Can you tell us how you're going to approach this gentleman operatively?
Okay, so his lesion is in the distal esophagus. Often you can approach these lesions easily, or it's the easiest way to approach it is either a left lower thoracotomy, and this is in the 7th intercostal space on the left, plus minus a laparotomy, and with this it would be an attempt to isolate the area of the lesion by separating the esophagus from the aorta as it enters the diaphragmatic hiatus. And this is the way that I would approach it. We'll have access on both sides.
No, your plan is to do what? To repair it or close the hole or resect it? What you going to do?
So repairing it, it's not going to work very well because the tissue is diseased. So I would rather go with a once-on resection.
Okay, so you are going to go in to resect the tumor, correct?
Yes, yes.
Okay. And how do you resect tumors in the lower third of the esophagus? What surgical approach, incision-wise, do you use for this?
You used a laparotomy and a chest incision as well.
Sorry, use what, sorry?
A laparotomy and a thoracotomy.
Which side thoracotomy?
The lower side is more favorable to the left side thoracotomy from what I've read.
But is that how you would normally do it for esophageal cancer?
No, I've seen in my center that they often just go to the right thoracotomy to do it.
Yeah, what operation is done usually for a tumor of the lower third of the esophagus electively?
Ivor Lewis.
Correct, Muhammad. Ivor Lewis, right? Was that you, Muhammad?
Yes, yes.
Okay, Ivor Lewis. Back to you, Ismail. What are the
Yes.
incisions what are incisions you're going to use for Ivor Lewis operation?
So it's a laparotomy, the left-sided thoracotomy.
Is Ivor Lewis operation a left-sided thoracotomy?
I got the impression, Prof, it was the right side. That's why I'm a bit confused now.
Okay, and I'm just asking, is Ivor Lewis, back to you, Muhammad. Ivor Lewis, where are the incisions? Muhammad, are you here? Muhammad, you here with us?
Prophets, hello?
Yes, I can hear you.
Ivor Lewis is a two-stage surgery, laparotomy with right thoracotomy.
Correct, that's correct. Right thoracotomy, a laparotomy and right thoracotomy. Back to you, Ismail, it's a right thoracotomy.
Yes.
Laparotomy, what you're gonna do when you're in the abdomen, can you tell us briefly?
So you would open the abdomen. You would start by mobilizing the area that you're trying to get to at the esophageal hiatus. The way you do that.
You're gonna resect the stomach. You're gonna resect part of the stomach, right? And the distal esophagus, correct?
Okay, yes.
Right, and before you leave the abdomen, what do you wanna do? Anything else before you close the abdomen?
You've resected the stomach and you've obviously now resected some of the esophagus and you want to anastomose.
Right, but before you close the abdomen, go in the chest, would you do anything?
Make sure that you can have a look into the left chest.
Okay, you cannot look in the left chest, Ismail, you're in the abdomen. You cannot look in the left chest. You would put a feeding J tube, correct?
Yes, okay.
Yeah, you would put a feeding jejunostomy tube, correct?
Yes.
Okay, now we're gonna close the abdomen and go to the right chest. And you're gonna resect the tumor, correct?
Yes.
Okay, are you going, this is the important question, are you going to reconstruct the esophagus after resection or not?
Yes.
So you're gonna do esophageal gastrostomy in this scenario, are you?
Yes. Yes.
But does everyone agree, guys, that we are doing esophageal gastrostomy in this scenario?
I don't think so, Professor, because there is perforation with this malignancy. Better to leave the anastomosis later, because esophageal anatomy has no cirrhosis, and there is a great leak.
Absolutely, 100%, Muhammad. That's absolutely the answer. So the answer to this case, guys, is you go and you resect the tumor. Point number one, we all have to know, there is no such a thing as repair of perforated esophageal cancer. There's no such a thing. This is not done. It's a contraindication to any attempted repair. The operation performed in this case is a resection of the tumor. And there is no non-operative management, Ismail, for a perforated esophagus either. Cancer, or perforated esophageal cancer. The management is an operation. And with an operation, you are going to resect the tumor. You have to resect the tumor to control the source. And you will leave the reconstruction for another date. And the reason for that is you have already mediastinitis, you have very unfavorable environment in the mediastinum, and you should refrain from doing any anastomosis at this point. So back to you, Muhammad Ali. You resected the tumor. You already have a feeding J tube in the abdomen. And so what you're gonna do now? And you're not going to reconstruct. What you're gonna do?
I heard about many ways for either to do esophageal exclusion with the broth of the two ends of the esophagus, with putting prophylactic chest tube or I don't remember now the second.
Anyone, guys, anyone, how we resected the distal esophageal perforated cancer. We are postponing reconstruction at this point. How are we going to conclude the operation? We already have a feeding J in the abdomen. How are we going to conclude this operation?
Assalamu alaikum, Prof. Can I try?
Yes, please. Go ahead, Mazen.
So I think, I think one of the options for this patient, if he is stable and we caught the leak early, we can do McEwen, so 3 stages esophagectomy, and we do the anastomosis in the neck. That will exclude the leak from the mediastinum, and it's better outcome. That's if the patient is stable and we caught it early, like within hours from the leak. This is one option. The second option, if we opt to do like damage control, we're gonna do a diversion of that esophageal stump. So some said they will do esophagostomy in the left neck and they leave it as a drain. And then we did already a feeding judge and we leave it for some times, then we do a reconstruction using the stomach as a conduit.
100%, thank you. That's exactly how the management should be, guys. So if you want anastomose, it's preferred to go in the neck. If you want anastomose, you prefer to go in the neck, or you can leave it for later. If you're leaving it for later, you can do. You have to divert the esophagus with esophagostomy, and you already have a J tube. Right. So let's just move on with the next scenario, guys, for 1 second here. Just before we leave this scenario, can I ask you, Mazen, maybe what if you you're in the chest and you could not get rid of the tumor? What would you do?
I will do the same thing, diversion. I will do esophagostomy and try to take as much as I can, and I will consider it not the oncological resection.
So how are you going to do the diversion? Can you tell me?
So on the left side of the neck, turn the patient to the other side. We're going to do anterior to sternocleidomastoid incision. Then we're going to take skin, platysma, and retract the sternocleidomastoid laterally. And we will find the carotid sheet also. We'll take it, try to retract it laterally. And then we're going to see the esophagus and try to differentiate between the esophagus and trachea. Take the esophagus and we just staple it. And then take the proximal part as esophagostomy and we take it out on the skin and we do a small hole like a stoma.
Right. I want to add one thing, guys, which I haven't heard, but it has to be emphasized because I noticed that it's often forgotten by you guys. Please don't forget irrigation and wash out at the mediastinum and placing mediastinal tubes if you're operating on these people. I really think it's very critical that you do lavage of the entire mediastinum, clean it up. That's what you're there for. So I think it's really important.
And
so
if I can add, if there is pleural contamination, it's contraindication for endoscopic intervention. You should have contained leak if you're considering stenting, and most of the time for benign perforation, not malignant perforation.
No, I disagree actually, Mazen. I think that stenting has been phenomenal in managing people with malignant perforation for one reason. It is going to convert the emergency that you have with perforated cancer into an elective operation where you can do your oncologic workup and do a proper oncologic operation in the future. No, I think actually stenting is a great thing. If you have somebody who's expert in the case, if you have the right patient, the patient is not sick, I think it's very appropriate to put stent in these people. It will convert the emergency into an elective operation. Okay.
Hi, Prof. Just a question.
Go ahead.
Yes, I wanted to ask, I understand the proximal esophageal diversion for the case, but the actual doing an anastomosis up in the neck, in the lower esophageal tumor that you've now resected, how are you going to get that up? Maybe I haven't seen it, that up to the neck, the two ends that you've resected, from which you have resected. Because you said don't do that anastomosis in there, rather not do it or do it outside.
Yeah, there is the McKeown operation is a 3-stage operation. So you have to make sure you mobilize the stomach, the gastric tube enough to reach the neck. Yeah.
Okay, so it's all about mobilizing.
Yeah, absolutely. But I'm not trying to make the talk about, you know, how you perform esophagectomy here, because we really want to focus on the approach to the actual perforation. The details, this is not a talk about esophageal cancer, you know? So that's why I'm trying to get you to say what you're going to do without going into details much about the oncologic workup and all this. So we'll keep moving, guys. Whoever is next can help me with this here. Anyone can pick this one up. A 20-year-old man with a little developmental retardation challenge is brought to the emergency room after ingestion of caustic drain cleaner. Who's going to work with me on this case? Anyone can work with me on this case, guys? Anyone?
If no one,
you can proceed the problem, no problem.
Sorry?
We can answer both me and Mazen, no problem.
Okay, right, Mohammed, we'll be with you here. Okay, Mohammed, let me ask you a question. Do you see that in Sudan or no?
Not commonly.
Did it used to be common? Because it is kind of relatively, it does happen here. Definitely was very common. It was very common in Egypt in all days. So, but it does happen here, but it happens on a suicidal note, not really, not mostly accidental. So, but you don't see any of this. It can be suicidal here. So. So let me ask you, this young person here is in the ER. What would be your first concern about it, Mohammed? The very first concern.
The ventilator is brought to emergency room after causative drain cleaner. The type of fluid he took. Is it alkali or acidic?
They don't really know, but why are you asking this?
Because alkali solution more aggressive than acidic and can cause stricture or dysphagia for this animal.
Right. So that's fine. Let's say we don't really know much about that, but what's the first thing that you should be concerned about when you see this case? If you notice, guys, that I guess that's kind of like the American board thing. They mostly concerned in the oral board, or if you want the OSCE that you have it, or the oral board. The concern here is not much of the theoretical discussion of things. It's what you are going to do now with the patient. And they always want to hear practical steps. I am going to do 1, 2, 3, 4. My concern, number 1, number 2, without much actually of the theoretical, discussion about things. So, what?
Okay, so this patient.
Let me make it a little bit closer, Mohammed. Before you even go to the ER, if you get that phone call that this patient is there, what question would you ask them? The first question, the most important question.
About the airway and breathing. Is he breathing now? He's talking.
Is it breathing or airway? Which one?
Airway comes first, definitely.
And why airway here?
It can cause laryngeal edema, laryngeal spasm, can cause upper airway obstruction.
Absolutely. The first question that you're going to ask in this case, and your first concern, is the patency of the airway. Patency of the airway. That's the first question you're going to ask. Okay? Now, how you determine the patency of the airway quickly?
If the patient is talking or not.
Correct. Now, let me ask you, you see this patient and there is a little bit of swelling around the oropharyngeal mucosa. Tell us what you're going to do now.
To secure the airway with the device, oropharyngeal tube.
So, it's not, what do you mean oropharyngeal?
Better to keep the airway, upper airway, patent with the devices, nasolaryngeal or oropharyngeal mask tube.
No, just explain it to me. What do you mean oral? What kind of tube is that?
I'm not sure.
Anyone, guys, what are we gonna do here if we're concerned about the airway? Anyone?
Elective intubation.
Sorry?
Elective intubation.
Correct. Orotracheal tube, correct? Right?
Yes.
Correct. Oroendotracheal tube, oral endotracheal intubation. So number one, Muhammad, is you are going to preemptively and electively secure this young man's oral airway with endotracheal intubation before the swelling that you see the beginning of sets in and you lose his airway and you won't be able to endotracheally intubate him. It's not oropharyngeal, it's endotracheal intubation, the tube that you use for general anesthesia to do an operation on the patient. So let's say that this is done. The patient has an endotracheal tube. Back to you, Muhammad. What we're gonna do now?
To complete the ABCs, the breathing.
He's breathing fine. His saturation is 100%.
To put NG tube for suction.
So you would put an NG tube.
Yeah.
Okay. Does everybody agree, guys, that we're gonna place an NG tube in this patient?
No, it's actually contraindication.
Good, Mazen. Why?
Because the mucosa is inflamed and you can cause perforation if there is none before.
Correct. 100%. I hope everybody heard this, guys. So what we're gonna do next, Mazen?
We can do CT scan and we can grade the injury according to the CT finding. So I think we have 3 stages, either normal mucosa, either inflamed mucosa or perforation, and we can act accordingly. So if it is a normal mucosa, and we can do G-scope within 48 hours from the injury. If it is mild inflammation, we can do the same. And if there is a perforation, we need to take the patient to theater.
Okay, so after endotracheal intubation, we're gonna go straight to CAT scan, is that correct?
Yes.
Does everybody agree, guys?
After stabilization of the patient, getting IV fluids, IV access, then we can go to CT scan.
Does anyone want to do anything before going to the CAT scan after endotracheal intubation, guys?
There is a, I read about the neutralization of the agent, if it's given by the history, antibiotics, anti-secretory therapy. We can do lavage, washing.
So you're gonna do, no, just a second, Mazen. So you're gonna do gastric lavage with this?
if I know the material from the history, maybe
Mazen,
I
what do you
can.
think? We're gonna do gastric lavage?
No, of course not. I think we can do chest X-ray to make sure there is no pneumo or hemothorax, there is no perforation before going to CT scan.
Now we got the right thing. Regardless, guys, even in not any case, what we do after endotracheal intubation in any setting is we get a chest X-ray for
Yeah.
trauma, for anything. So please get a chest X-ray first, guys. Please get a chest X-ray. I guess what we're trying to do here, guys, the key thing, think practical. Think exactly you're there, you're seeing this patient. You just intubated this patient. The patient is getting a chest X-ray after that. Not just because it's intubated, because you may have free air. So let me ask you now, Mazen, you do the chest X-ray and you do find mediastinal air and pneumothorax. Now what? Does that change anything?
The chest tube.
Okay. You agree, guys? Chest tube?
This is most probably perforated esophagus.
Okay. So you're gonna put a chest tube and that's it, or what do you?
According to the patient, if he is stable or not.
What do you mean?
Perforated esophagus with this corrosive material, I can put chest tube because it can cause mediastinitis. Then if the patient is stable, I can take him for further imaging to delineate the site and the size of the perforation. If he is not, this patient may need wash and irrigation against this material in the chest. I'm not sure about that.
Mazen, what do you think? Chest X-ray showing pneumomediastinum and pneumothorax.
So pneumomediastinum is, that means there is a perforation and it's indication for surgery. We need to fix that perforation.
Okay. What surgery?
There is a high risk of mediastinitis. So
what surgery are you gonna do?
Depend on the level of perforation. So if it is proximal perforation, we're gonna do right thoracotomy. If it is a distal perforation, we're gonna do left thoracotomy.
Tell us exactly how you're gonna approach this patient first time when you're doing an operation. Where would be the first cut?
So if it, as I said, if it is, let's say it is
So even with free air and pneumomediastinum, you need to get, you're telling me that you need to get contrast study?
no, not CT scan.
Yeah, CT scan with contrast, right?
Yes.
And the reason you want to do that is you want to see where the perforation is, right?
Exactly, yeah.
Because it's going to make a difference, right?
Yes.
Do you agree, guys? Does everyone agree that knowing the site of perforation here is going to make a difference in what I do as far as surgery is concerned? What kind of operation? Do we agree on this? Everybody agrees, guys?
Yes.
In what way?
Stability of the patient.
No, I'm not talking about stability. I'm talking about the extent of the operation, the type of operation. So back to you, Mazen, just so I understand. Are you going to do resection?
So we're gonna see if it is small perforation, we can do debridement and primary repair. If it is a big laceration or acoustic injury, we can do diversion.
So you are going to repair hole in the esophagus with caustic injury. You think this can be repaired?
In this setting, no.
Sorry?
Usually not.
So why are you saying they're going to repair it?
I'm mixing up things. I think we need to resect. No, we can even either resect or divert. So we can leave the esophagus inside if it is a big injury, and we do like esophagostomy.
Why wouldn't you resect?
No, we can resect.
So, but why wouldn't you?
No, I said we can.
So, can somebody, guys, tell me how you are going to manage perforated caustic esophagus operatively? What is the operation of a choice in this case?
We
Depending
can do transhiatal esophagectomy as well.
Transhiatal esophagectomy is the operation of choice for management of perforated caustic injury of the esophagus. This is key, guys. You are not going to do partial esophagectomy. You are not going to cut even this man's chest. You are going, the first incision you're going to do in this case, as long as you know that you have perforation caused by caustic injury, the entire esophagus is coming out because it's burned and it's erosive esophagitis. You cannot preserve it. You cannot do primary anastomosis. You cannot close a hole. And it's a benign disease. You don't need any lymph nodes, and you can avoid a thoracotomy. So the question now, what is the first incision you are going to make on this young man here in the operating room? Where is the incision placed?
Laparotomy. So we need to check
Correct.
the stomach as well.
It's an upper midline incision. Now you're getting it. It's an upper midline incision. You are going to do a laparotomy, and the first thing you're going to do is to check what?
Stomach, if it's involved or not.
How are you going to check the stomach?
So we can see from the external marking, or we can...
Hello?
Yes, we can see from the external marking if there is
outside, you're not really going to see much. So how are you going to check the stomach, Mazen?
We can do gastrostomy and see if there is the mucosa from inside healthy or not.
Correct. You are going to do gastrotomy. And in fact, some people recommended that taking biopsy of the posterior gastric wall to make sure it's viable. Now, let's say the stomach is viable. Scenario number one, you are going to do a gastrotomy, and the stomach is viable. What would you do now?
If it is possible, we can do reconstruction in the same setting.
Is that ever recommended? Is that ever recommended, Mazen?
No.
Never.
Ideally, it should be staged one after, they said 3 months to 6 months.
So please, if it's not recommended, do not say that to the examiner. It's not right. You know, do not tell him that you're going to do reconstruction because it's contraindicated.
Yeah.
So what you're going to do now? We have a gastrotomy done and a viable gastric wall. What's your next step now?
I will do feeding judge.
Correct. You're going to do a feeding jejunostomy, and what else?
And so we already transect the OG junction. So
we haven't. No, we haven't. We haven't transected it. But are you going to?
So we will do that, yes.
Okay, you're going to staple off the gastroesophageal junction, okay? What you're going to do with the hole in the stomach you created?
We're going to close it.
I have a better idea instead of closing.
You can, but big, but if you're going to use the stomach as a conduit, it's better not to use big in this situation.
No, it's not really, it's not a peg, it's a G-tube. Why you want to put a G-tube here?
So to drain the stomach, acidity.
To decompress the stomach, you're stapling the gastroesophageal junction, and you want to make sure that you're decompressing the stomach, right? So you're going to decompress the stomach, you're going to put a J-tube, you're going to staple the gastroesophageal junction, and now what? What you're going to do now?
So we can bluntly dissect the esophagus up to the.
Sure. So you're gonna, again, we're not talking about the technique of esophagectomy here. We are focusing on how to manage perforations. So you're gonna proceed with transhiatal esophagectomy, correct?
Yes.
And please don't forget to place 2 mediastinal tubes
Drains.
to wash them. What the examiner really needs to hear here, guys, is you washing the mediastinum with at least 20 liters or so of saline or something. You really have to irrigate the mediastinum in these cases. The mortality here is related to mediastinitis. The mortality is related to mediastinitis. Make sure you irrigate the mediastinum copiously with at least 20 liters of crystalloid. Right. So you're gonna put a tube esophagostomy, correct? In the neck, correct?
Left neck, yes.
Okay. What's your future plan?
So, as I said, after 3 to 6 months, we can use stomach as a conduit.
Okay.
Pull through.
Change of scenario, which we do very often. Change of scenario. You go in the stomach and the stomach is dead. What you gonna do?
Total gastrectomy as well. I will add total gastrectomy as well.
Okay, and?
So the same thing, feeding juice.
Okay, and how are you gonna reconstruct him in the future?
So in the future, we're gonna use the jejunum as a conduit, or the left colon as a conduit.
The colon, you're gonna do colonic interposition, correct?
Yeah. Yes.
Correct. Okay, right. So third case, and anyone can work with me on this, is a 70-year-old man is brought to the emergency room with severe chest pain after repeated episodes of vigorous vomiting the night before. Anyone can work with me on this, guys. Anyone? Can anyone work on this case with me, guys?
I don't mind to go again.
All right, Mazen, go ahead. How are you going to investigate this patient?
So this patient is most likely having malarious syndrome. That's a partial tear of the distal esophagus.
No, just a second, Mazen. This is not a good start. Is malary-wise tear causing pain after vomiting?
No, this is Burhoff syndrome.
Thank you. Thank you. Thank you. Big difference, guys. Both of them are occurring with vigorous vomiting, and 2 things can happen in the esophagus. Malary-wise tear, which presents how, Muhammad? How does it present?
Malarious, there is bleeding. And
Upper GI bleeding can be massive.
yeah.
And what's spontaneous perforation of the esophagus or Burhouse? This is full thickness perforation.
Yeah.
Full thickness perforation of the distal esophagus. Totally different story. Both of them occur after vigorous vomiting. Okay. Mohammed, you can carry on or can go to Mazen, that's fine. How are we going to approach this patient? How can we approach this patient, guys?
So we're going to start with the resuscitation. I'm going to put IV fluid and start antibiotic for him as well. And then depend on the patient's situation. If he's stable, I can send him for CT scan to see if it is a contained leak or not. And if he's not stable, we need to take him to theater.
Okay, so good. So now we got the idea. We start, this is what we want to do. IV fluids, antibiotics, and then hemodynamically stable kind of thing, workup, CT scan showing free extravasation of contrast into the left hemithorax, and again you forgot the chest X-ray.
Yeah, we can start with the
Chest
X-ray
X-ray,
possibly.
always chest X-ray, guys. Okay, free extravasation of contrast in the left hemithorax, Mazen.
So that's mean it's not contained, and that's mean he will need the operation.
Okay, tell us how you are going to approach this patient operatively.
So if the theater is available and it's left hemothorax involved, so I will do left thoracotomy.
Where? Which rib space? Intercostal
Fifth,
space?
so it's a distant, I will say 7th, 8th, because it's a distal one.
It's a 7th intercostal space, meaning you cut on top of which rib?
7th intercostal, so it is above the 8th.
Recording.
Okay, so 7th intercostal space is above the 8th rib?
Second, above 6.
Above the 6th rib, correct?
Yeah, above 6.
Okay, so you're gonna do the thoracotomy. Tell us what you're gonna do next. You in the left chest cavity. We wanna hear in details this time how you are going to accomplish this. Are you planning to repair this?
Yes.
Okay, tell us how you're gonna do that, because
So
it's key of how you're gonna do this.
So the first, I will ask the anesthesia to have a double lumen tube, so they will help me to deflate the left side of the chest, and they will intubate the right side. Second thing, I will put the patient on right lateral position, and I will keep his pressure point protected with the gelo bag or things like that. And then we're gonna start with, after scrubbing and finishing WHO checklist, we're gonna start cutting with the 7th intercostal space. We're gonna start from mid-clavicular line and going back to just behind the scapular curved incision. We're
That's
gonna
fine.
go to,
Let's say you enter the chest cavity, that's fine. And by the way, the 7th intercostal space should be on top of the 8th rib, you're correct. So anyway, keep going. You're in the chest cavity. How are you gonna find the esophagus?
So the first thing, we're gonna mobilize the lung. We're gonna ask the anesthesia to block the left tube of the lung to deflate the lung, and then we can take off the inferior pulmonary ligament, taking care not to injure the vein there. And then
Excellent. Keep going.
we're gonna retract the lung laterally, and then
it's actually cephalad. It's up top.
Lateral and above, yeah. And then we're gonna see the esophagus. So usually what we do longitudinal extension.
No. You haven't seen the esophagus yet. You only retracted the lung. You haven't seen the esophagus.
So we're gonna open the pleural cavity covering the
you are
esophagus and
you are going to incise the mediastinal pleura, correct?
Pleura, yeah.
Okay, and now you can see the esophagus, and you see some mucosa sticking out from a 1 centimeter hole in the esophagus. How are you going to handle this?
So what we're gonna do extension, longitudinal extension of the mucosal tear to expose the musculosa tear to expose the mucosal tear.
So you are going to do extended myotomy first, correct?
Yes.
Why do you do
that? To expose the injury of the underlying mucosa.
And why do you have to do that?
Because sometimes there is a bigger laceration in the mucosa than in the muscle layer.
Excellent. I hope everybody's listening to this, guys. These are key elements in the management of this case. And when I say key elements, if any of our residents here or trainees is sitting for an oral board and is not describing this as it is, they probably would fail the question. Okay, you're gonna extend the myotomy because the mucosal tear commonly is bigger than what you see on the muscle tear. You extend the myotomy and then what?
So we're gonna try to do debridement of the mucosal layer, and then we're gonna close the mucosal layer with absorbable interrupted suture, and then debridement of the muscular layer as well, and we're gonna close it with continuous. We can use absorbable, long absorbable like BDS.
Okay, or you can use
And
non-absorbable.
then, yes, and then we're gonna use something to buttress the repair. We either use the pleura, we use intercostal muscle, or we can intercostal muscle. We usually use that as a buttress to prevent the fistulization. And then we're gonna put two drain, one in the apex, one in the base of the lung, and we can close.
You sure?
There are two techniques, Prof. I think pleural flap, or you can use fundus of the stomach. You can have
Sure,
it from
so
down.
again, I reinforce that. But I think you didn't do the most important part of the procedure.
You have to check for the anastomosis for the repair.
No, imagine, I think you forgot the most important part of the procedure, that otherwise it's going to kill the patient. Imagine, I think you didn't do the most important part of the procedure, that was going to kill the patient if you don't do it.
Most important part.
Yeah.
The mediastinal drain.
20 liters of crystalloid irrigation of the mediastinum.
Irrigation of mediastinum.
20 liters of lavage of the mediastinum for mediastinitis. 20 liters of crystalloid irrigation. If you don't want to say 20 liters, it's copious irrigation. You cannot forget to say this. This is what you're here for, is to deal with the mediastinitis. And you're gonna place two mediastinal tubes and the left side chest tubes, correct?
Yes.
How do you make sure you're not narrowing the esophagus with the closure?
So we can do on-table G-scope to see if you can go through the repair or not. But you should be careful not to inflate much.
Let's say you can go through the scope, the repair with the scope. Does that guarantee you that it's not narrow for food? How much French is the EGD?
For about 15 mil.
No, so it's about 35 French, right? Maybe at most 32 French. And what do we want the esophagus lumen to be?
So from what I know, if you can pass the G-scope, the patient will tolerate semi-solid food.
Well, he wants actually to eat solid food. How about that?
Yeah, we can. So if we can, some people will pass a bougie, but I don't think it's a safe idea because there is a risk of perforation, but it is an option.
You're actually in the chest, so you can guide the bougie, 45 French bougie down without causing perforation. You can guide it, right?
Yeah.
So the anesthesiologist is there. He's going to take the NG tube out, or there is no NG tube in the first place. He's going to put one later on, and I'm going to tell you why. And he's going to pass a 45 French bougie, and you're going to do a repair over that. Let's say the repair is done, and the mediastinal irrigation is done. What you're going to do before you close the chest, and reinforcement of the repair is done. Anything else you want to do?
You said it already, pass NG tube.
Where are you going to place the NG tube?
So we're going to try to pass it beyond the pylorus.
Why? Why do you want to do that?
We're going to use it as a feeding tube as well.
I have a better way of feeding him that we should do.
So
And I have another reason to have an NG tube.
So the NG tube is to drain the stomach content.
We're going to leave an NG tube above the level of the repair in order to have a contrast study performed in 2 or 3 days, especially on a sick patient who's probably going to be in endotracheal tube and not able to swallow. So in order to perform a swallowing study, you can place an NG tube down to the level of your repair and fix it at this level. So you can put contrast study to examine your repair in 2 or 3 days if the patient is not awake and not eating. Then you're gonna close the chest, flip the patient, do a midline laparotomy, and put a G tube for feeding, correct?
Mm-hmm.
Or even better, G tube for gastric decompression and a J tube for feeding. Why would you not want to feed the stomach in this case? And why would you want to put a G tube still, even if you're not feeding the stomach?
So I'm not sure, but maybe to prevent the reflux of the stomach acidity to the repair.
To decompress the stomach, to avoid any increase of intragastric pressure and vomiting again, and the patient will compromise your repair one more time. So you want to decompress the stomach, however, feed the small intestine, let the repair here, and you have a tube above it to examine it with contrast study, 2 or 3 days. If the patient is not awake and can swallow the contrast himself. Don't forget the broad spectrum antibiotics. I think it's critical. And please do not forget the mediastinal irrigation. It's really important, guys. So I'm not sure how common is that going to be on your test, but I can tell you that right now, that's what we tell our surgical trainees. There is no one of our surgical trainees who's going to go through the oral exam without getting a question about esophagus and about breast. It's just not going to happen. You get 12 questions for your oral exam, for your oral board, 12 questions. 2 of them, one is guaranteed breast topic, and the other one is guaranteed esophagus topic. One of the very common esophagus topic that we get is perforated esophagus. Very common. They also put esophageal cancer and other things, but perforated esophagus. You cannot go to the oral board without knowing esophagus really well and breast really well. So I'm not sure, maybe it's not as common in your asking.
Yes. Can I comment, Prof?
Sure, please, yes.
Just
Well,
about to welcome you, Professor Rashid.
Thank you. Well, thank you very much, actually. Actually, these entities are quite rare. I mean, the Borheim syndrome and Murray-Weiss, I think just a book entity for us here, rarely seen. And the ingestion of caustic material, in actual fact, the suicidal attempts is not common, but the few ones we had, they drink something called sibgha, hinna. They use it for their decoration in their hands, but this causes severe edema in the tongue, so they get an airway obstruction. And I think early on we used to do tracheostomy for these patients if you don't have, I mean, the facility for intubation. But another entity is that, you know, we have got esophageal varicesia, and they used to give injection sclerotherapy. Now it is changed to rubber band. The injection sclerotherapy, we have some perforations, and these are benign, so probably a chest tube and observation. And some of them, they present late with a fistula between the esophagus and the bronchus or the trachea, and we have to operate on them electively. The ingestion of caustic substance, I mean, from the kitchen. I know in Egypt, there was really quite a number of cases. I remember presenting a child probably coming to the kitchen and
absolutely
accidentally taking something.
It's not
That's right.
uncommon
And
to use the caustic material
caustic.
for washing clothes and all this. It's like bleach. Yeah.
Absolutely, that is it. But it's not actually common here. But I remember, I mean, probably 2 cases, young patients at the age of 20, but they came late with the stricture, so we have to do a McQueen operation in 2 patients. So my question is that if you have got it in the early stage and the breathing is all right, probably, I know this is just about perforation of the esophagus, but in this situation, probably the emergency management of giving steroids. I don't know whether you would like to pass an NG tube to establish the track there before things get worse, and probably, I don't know whether you have got any experience in the emergency.
I think we'll avoid NG tube unless we do EGD first. So I know the CSAP. I know the CSAP book now talks about CAT scan for grading caustic NG, but ideally we'd like to do an EGD to grade it. If there is a grade 1, yes, you can pass an NG tube and you can pass the wire, so you can later on do dilation. I think steroids now are out of question on those. We don't use them anymore. So, but I think the trick that we always like to hear from the candidate is the concern about the airway first. So
yes, that's right.
And esophageal cancer, you don't get esophageal cancer?
Well, we had it actually. It's quite common, I mean, here, and mainly of the squamous type. But now the trend is changing. I mean, we are getting now more adeno. I mean, you know the graph probably. People in the cities, obese patients, and this sort of diet, we are getting adenocarcinoma. But young patients coming mainly from the eastern parts of the country. They usually come with squamous, young patients, mainly females, and middle and upper third, and quite a number of these cases. And we have quite a good, a lot of these patients. Esophageal cancer is quite common.
We do have esophageal cancer here. It's a common thing also that we operate on a lot. And I think, Mohammed, next time, I think another thing that, because sometimes maybe the emphasis on the exam in Sudan may be a little bit different from the United States. So if the topics, some of the topics we choose are not really that common or emphasized on the exam in Sudan, that's fine. We can probably choose different ones. But here, perforated esophagus is on every written exam, and very good chance that our trainees will get a case of perforated esophagus on their oral board. Very, very likely, actually.
Well, so, I think it's important to know about this, because I mean, things will come even if it is just very rare, but if you don't have it at the back of your mind, you might miss it and mismanage it. Yeah, I agree.
Right, exactly. Yeah. So we'll take any other questions or comments, guys. That's fine.
Prof, can I ask something about acoustic ingestion?
Sure.
So here in our institution, what we do first, we do CT scan, and it's grading from 1 to 3.
Good.
1, we are not doing anything. 3, we need to take the patient to theater. And 2, we're gonna do G-scope and then decide from 1 to another 1 to it's ABC. Actually, 1 to 3 ABC. So then the management is different. But I read some people started with the G-scope first. Is it an option?
Yes, that's what we do here. Yeah. Everybody gets an EGD unless you have free air on a chest X-ray.
And you do CT scan after that or not? There's no need.
No, if you have free air, you're going for total esophagectomy with transhiatal.
Yeah. Without free air. So let's say you do G-scope and it is 2B, that's circumferential ulceration.
That's fine. You can do a CT scan. We use a lot of CT scans. Yeah, sure. Yeah.
Okay.
And no steroids, obviously. No steroids.
No.
I'm not sure if are you still using steroids, Mazen?
No, we never used them.
No steroids in this case. No. Yeah.
No.
All right. So thank you guys, and inshallah we'll see you next. We'll talk with Muhammad about next time and next day, and we'll see what we're gonna do to make the timing good. Okay.
Thank you both.
Thank you. Thank you.
Thank you, Professor Gamal, for this nice presentation. Actually, it was very interactive. I would like just to remind Professor Rashid, once we had a patient, he was a renal failure patient, and then he had dialysis through a cervical catheter, I mean subclavian catheter, and there was a tracheoesophageal fistula. Maybe this is one of the very rare cases to present, I mean, even in the literature.
I'm sorry, say the case again, I'm sorry.
Once we had the patient, he had tracheoesophageal fistula secondary to insertion of dialysis catheter. It was traumatic perforation of he presented very late with the fistula.
After putting a dialysis catheter in the vein, in the subclavian?
Yes, or? Yes. It was, I mean, it was just maybe it went out of the vein. Actually, it just perforated.
How late was the presentation, Reem? This is pretty late.
It was an year later. Yes, it was a year later.
And the catheter was still in place?
No. It was removed.
But how do you know it was caused by the catheter?
Because he was not having any other history. This was the only thing that happened. Maybe the professor remembers this case.
How did you fix it?
Just cervical approach. And then we separate the trachea separated from the esophagus, and then the esophagus was repaired in double layers, and the trachea was repaired also with the interposition of a muscular flap, and that is it. It went very well.
It's good. It's really good. All right. Yeah. Interesting. All right. Thank you.
Yeah.
Thank you.
Thank you very much.
Nice.